Welcome to Optimizing Effective Cancer Care at NIH, offered by an unrestricted educational grant from Carestream. I'm Mary Tierney, the Chief Content Officer of Clinical Innovation and Technology. The National Institutes of Health is known for innovation. This time, they're working with the National Cancer Institute in creating more information-rich and quantitative reports to help oncologists in the intricate care of cancer patients. Leading radiologists at NIH are using technologies such as semi-automated cancer lesion management and multimedia reporting software to reliably, consistently, and quickly distribute reports in oncology follow-up and treatment planning. Oncologists at NCI are the benefactors, gaining more quantitative and comparative data. So as you'll hear from Dr. Les Folio, who is a radiologist at NIH, and Dr. Tito Fojo, who is an oncologist at NCI, this is leading to more effective communication, clinical insight, and confidence amongst physicians in longitudinally tracking cancer lesions with more quantitative and structured reports and better communication with patients as well. So quantitative reporting clearly is the way of the future. So let's hear from Dr. Folio.
Quantification needs to be more integrated into our current reports. Traditional training of radiologists is to produce a qualitative report, but the demands are changing. We're getting a feel for the fact that we do need to be more quantitative as radiologists, include measurements in our report, and if the automation can help us within PACS, then we may not need to rely so much on information processing services. That's my goal actually over the next year, is to incorporate new automation and segmentation and follow-up into my assessing of the patient. And as the segmentations occur and the follow-up which we've created over the last couple of years with Carestream Health, the automation will then wrap itself around the lesion automatically, which we'll get a chance to see. Then when we apply the follow-up, it takes every lesion that's been previously measured, we'll find it, segment, and measure for us, and then export these to our reports. But more importantly, we're working on taking these numbers that come from the digital measurements and exporting them directly to the medical record.
I think in any new technology, you want it to be easy. You want it to be accurate. As an oncologist, you want it to be better than the previous one. And better could mean that we're able to detect things that we couldn't before, or able to measure accurately things that we couldn't before. In prostate cancer, many decisions are made based not on radiological findings because they're difficult to assess or they can't be found, but rather on the value of PSA levels in the blood. If we have the PSA equivalent from a radiologist, that's going to be revolutionary.
With our study in AJR, American Journal of Rankinology, we published our experience on applying this new segmentation system in what's called the lesion management application. And the lesion tracking tool is what allows us to take the automated segmentations that are done initially within potentially our workflow to then follow up in one button to be able to find every previous segmented identified lesion and automatically identify and measure in the follow-up exam. Our conclusions in AJR were that the segmentation and the follow-up was more consistent, it was more accurate, and it saved time, cutting the time in half for the follow-up lesions.
A radiologist doesn't want to spend a whole lot of time measuring a whole lot of lesions if it's not going to be of any value to the clinician. If that can be automated, if it can be made easier, if it can be made reproducible, if it can be made that it's used over and over again when the patient comes in for an evaluation, then that'll be much more valuable. And the practicing clinician then will have not this subjective assessment of what's happened to the lesion, but actually some hard numbers to really look at it and make more informed decisions.
I retired from the Air Force in 2009, and research I was doing at that time, because I had experience in Iraq in a combat hospital, we were applying a localization capability within the CT imaging and the PACS to be able to localize blast fragments and ballistic fragments. So one study that we had published in the Radiology Journal several years ago was taking what we called Cartesian positioning system that we identified in another study, where we could take XYZ points anywhere within the body. A person was shot, for example, and take these 2 points, extrapolate them to the location of a shooter. And Carestream has mastered the ability to register over time. So similar to what we were doing with Cartesian positioning system for ballistic fragment identification, we're using in cancer. The first study that I was interested in doing was with metastatic melanoma, because the distribution of the melanoma skin lesions was similar to blast fragments, where they were chaotic and not really based on organ systems. So the first study was published in Academic Radiology last year, describing the success of finding lesions. And we were between 70 and 80% consistent in finding prior lesions. The registration was right on. The registration that we now use every day in our daily practice here at NIH Clinical Center, that works almost without fail. The identification of lesions is about 70 to 80%, but that's improving across the board. The current method of measuring tumors, RECIST 1.1, is to look at axial scan slices as we have traditionally, to take then the longest dimension that we see on that axial slice. The obvious issue is, without taking a volume, is if we, for example, were to look at a football and I were to hold up the football in the oblong perspective here, it would have a certain measurement between the ends. But if I reorient this football to you right now, the distance between the ends becomes shorter, and that's very intuitive. When we look at the axial slice, an oblong lesion in the bowel, for example, these often will reorient and will then shrink or grow just based on its orientation, even if the tumor size didn't grow. So from this point on, we are starting to measure volumes in addition to axial dimensions, because we believe that's the future. It makes sense. It is a better representation of tumor size.
Tracking lesions could easily become the standard of care. And if it becomes, really reproducible and everybody seems to be able to use it in a comparable way, then it'll just be widely utilized. Moving into the community care setting, that will be, I think, number one, very valuable, and number two, likely to be easily embraced. And by that I mean that I think anything that makes an assessment easier will be embraced. I think that most radiologists would rather not spend a whole lot of time measuring things in a difficult way if they can do it in an easier way.
First, I'm going to demonstrate how I can register between the baseline exam and 2 follow-up exams. And so the registration process is a mouse click, which I've done. So now everything is equally sized. The patient lost weight here, then gained weight again here. I want to demonstrate this liver lesion here in the left lobe. I'll do it on this particular exam since it's more conspicuous. You can see in the low density region, that's the lesion with a ill-defined margin surrounding that. So what radiologists do, standard of care these days, is to measure the lesion by coming across with the digital markers. What's different here, as you might have noted, is that the lesion management application has taken my linear measurement and also applied a volume to it, also found where the longest diameter was. I didn't pick the slice that actually had the longest diameter. It selected that for me. Now that this lesion is measured, and we have other lesions that are measured that I did earlier. So all of these lesions and the segmentations have location information, such as lung or liver for this particular one, but they also have this what I call GPS coordinate within the body, or Cartesian positioning system that we termed it in the military. Now that we have this segmentation on this particular exam, say this was a reset baseline, now we have this follow-up, and I can look for the lesion here and measure it again, but the automation is such that I don't have to. And now the registration machine will look at the global registration, which these are all matched up. But now that I apply this lesion tracking tool here, it informs me to click on the reference image first, the baseline, then the follow-up. Then what the lesion tracking does is then find every prior lesion. In this case, this patient has 20 or 30 lesions that we're following over time. It's a little complex. And we're looking at it at 3 different times. Now I can just go to the Report tab, and this is after I've already done my qualitative assessment and my dictation. Now I can plot the points of all the various lesions that we've looked at, and some are getting bigger, some are getting smaller. These numbers will then determine whether or not the therapy is working over time, because it's just a monumental task for a radiologist or oncologist to look at this metastatic disease, which you can tell is very troublesome. There's metastatic deposits all over the lung. Anything that is not dark here is a metastatic lesion from this very aggressive sarcoma. And the ability to follow these up, you can see if you're measuring many lesions, again, that can be monumental without tools that automate the process to allow for segmentation. We realize that we need to be more quantitative, and we need to embed the measurements that we're obtaining in a digital format within our reports. And in order to do that, the automation is the natural way to get to that point.
We could see this sort of technology then being used so that not only your patient's data, but the data from hundreds and thousands of patients with a similar disease being treated in a similar way can be stored someplace that you have easy access to it. Obviously, it's all anonymized, okay? But you have really easy access to this data, and you can see how well a therapy is doing in your patient compared to all the other patients that have gotten this treatment. And then even though you know you're not going to be able to cure your patient with this therapy, you will know this is really having an important impact on this patient, and I should continue. The possibilities really at some level are endless. Once we have something like this in place, then, I mean, enormous number of possibilities.
Welcome to Optimizing Effective Cancer Care at NIH, which is offered from an unrestricted educational grant from Carestream. I am Mary Tierney, the Chief Content Officer for Clinical Innovation and Technology. And thank you so much for joining us today for the live question and answer portion of the webinar. We have a lot of questions that have come in that have already been submitted, but if you would like to go ahead and submit a question, please just type it into the Ask a Question box on your dashboard. And I am very pleased to have both Dr. Les Folio and Dr. Tito Fojo joining us today to answer whatever questions that you have. Dr. Folio is a staff clinician for Radiology and Imaging Sciences at the National Institutes of Health Clinical Center. And Dr. Fojo is the head experimental therapeutic section and a senior investigator at the Center for Cancer Research at the National Cancer Institute. So doctors, we're going to go ahead, and I'm wondering perhaps maybe Dr. Folio, you could take the first question, which is kind of broad. You describe these reports as quantitative and comparative. What is included in the reports?
The reports can include, in addition to the traditional radiologist report, which is qualitative, it can include quantitative measurements that were taken during the read or doing an additional read in information processing or another section to someone dedicated to measuring tumors within PACS, where the actual measurements are exported into a tabulated and graphical report that shows the current measurements in comparison to the prior measurements, and these can include tables and graphs to show the trend of either better, worse, or same as far as growth in comparison, progressive development, and RECIST measurements. So it can do also the calculations and key images.
Okay. So another question, it says how do you integrate the measurements and images into the reports? So maybe you can give us a little bit more background on that?
The integration,
is that information pre-populated, or how does that happen?
It's not pre-populated. One has to open the report or open the images the report. And traditional workflow is to have the images and dictate a qualitative report based on the images with a few measurements. The quantitative report can include the current measurements, the prior measurements. These are populated once those measurements are taken. Since much of it is either semi-automated, such as the first baseline exam, for example, where one will click on a lung lesion, then it'll automatically segment, then that will then automatically export to the lung lesion area. One clicks on the lung tool that designates it as a lung lesion, for example, and then say there's a liver lesion. One has to stretch the calipers across the lesion. It's automatically segmented, or semi-automatic, since one has to click on it and stretch the calipers as the traditional caliper measurement. Then when that is segmented, it's automatically exported to the liver tab and so on. For the follow-up exams, this is done fully automatically and successful about 80% of the time, according to one of our research studies and our experience, where the follow-up tool is clicked, then every prior lesion that has been measured, however it has been measured, whether semi or fully automatically, then will be compared automatically to the prior exam, and those are filled in instantly in the appropriate areas.
Okay. So is any information then, the measurements then are directly loaded into the report, and you don't have to add those in, correct?
They can be added directly into the report and linked into the report. We're still working on that and how the workflow can occur, since we're not currently implementing that particular tool, but that's part of the idea. Yeah, where it would be easier for a provider to see, okay, now they're talking about the lungs and these are the lesions that are there, and these are the two that were measured, for example. Those would be ideally hyperlinked. One clicks on those, and then it takes one to the measurements that were exported to the quantitative report. But that part of it still needs to be worked out at our institution. Some may be further along on that than we are.
Okay. There's a lot of other questions too, but maybe Dr. Fojo, you can get involved in this one too, pertaining to how you're sharing some of this information with patients.
I mean, I think that really hasn't made a difference. I mean, I think you share the information in the same way that you did before. I just think that what it would have an advantage of is if it was some standardization across academic centers, and especially across centers, whether they're academic or not, in terms of how these things are measured. Then it would make more sense to the patient, who sometimes are befuddled that you're describing growth in some lesions that haven't been described before. You're describing it in a different way that it hasn't been described before. And so if there was some, systematic way to do this, that it was generally agreed and that everybody was sort of on board with, it would make patients' interpretation of the data that you're giving them much, much simpler and easier for them to understand. So I think that's the value of it. But in the end, if someone has progressive disease, you can't tell them, has cancer and their disease has progressed, you can't tell them that in any nicer way, knowing the exact measurements, than if you don't or whatever.
Right, obviously, yeah. I mean, the visualization also is, a reality check too, I guess, in some very negative ways as well, but a reality check.
I mean, what I said is not to, I mean, I've been here for 32 years, and I was thinking about it. I have probably seen reports from 10,000 different radiologists over that time, because, the patient will come and we get everything in their history. The majority of our patients have had multiple lines of therapy. They've had, countless imaging studies. And so I've probably seen 10,000 reports from radiologists. I doubt that any two were alike. It's remarkable that radiology training is such that there has not been the standardization of that maybe should be. And something like this could help to standardize that. And at the end of the day, information sharing is what's important. So anything that simplifies that information sharing and distills it down to a common language and a common metric will be exciting, will be fabulous, will be really, really good.
Yeah, that is. No, I mean, maybe I can extend on that. Is how has this changed any interaction among the physicians? Perhaps Dr. Fojo and maybe Dr. Folio as well could talk about that.
Well, we have yet to completely implement this new system since the latest version is still being tweaked, and we're working on that and designing it to be optimized in such a manner that this can as Dr. Fojo was relating to, be more structured, more standardized, and graphical. But what we have done over the last few years is apply the registration, both global and refined registration, where I believe that's helped oncologists a lot more in referring to images, registering across time, co-registration temporally, and easing the comparing. So that part has been mastered and implemented, and it's easing our work in radiology, and I believe using the oncologist review capability. We're also, I'd like to mention, we're doing a survey of our oncologists here at NIH, NCI, to see where we stand with the traditional reports, and after we implement this over the next year, more widespread, to then take another survey to see how this improved quantification has helped. That's my perspective. Maybe Dr. Fojo has his perspective on what.
My perspective again would be that anything that standardizes it is good. Even at the NIH, so as clinical researchers, we usually have what we call the index lesions that we're following. Right? We decide we're going to follow 3, 4, 5 different sites of metastasis, for example, in a patient, and that's what we're looking at over and over again. But it's interesting because there's always been a disconnect between what we're doing and what the radiologists are doing. And at the NIH, like in so many places, oftentimes the person reviewing this cycle's X-ray or imaging study is not the same one who reviewed it the previous time. And it's interesting to see how they'll pick different things to focus on and to look at. And that's fine. Okay, I want to know about everything in the patient, but I also wanted to know about some lesions and how it's progressing along, and especially if you're altering the therapy, if you've altered the dose, if you've changed courses in your therapy. You don't want to now be looking at 2 different lesions than you were before and knowing what's happening there as opposed to what you knew before. So I think that this will simplify communication between radiologist and the clinician, and also minimize the thing of having to go to the clinician and say, well, that's fine, that's all well and good, but what we really wanted to know was about these lesions. I mean, it duplicates the work for them, for us, so anything that streamlines this, it makes it consistent, that everybody's looking on the same page, I think all of that will be valuable, not only at the NIH, but everywhere that X-rays are done in cancer patients, for example.
So Dr. Fojo, do you see that this, we talked about, standard of care and the need for, some kind of standard among reports and things like that. Do you see something like this as evolving into a standard of care for oncology follow-up?
Oh, absolutely. I think I'm surprised that we don't have this even further along, that, we've got therapies, we try them, we know how effective they are based on some metrics that are done in clinical trials. Then it gets out to the real world, and every physician has a different metric. And a lot of times this metric is based not at all on any measurements, but rather on some reading by a radiologist that is subjective in what they say on the reading. And it becomes really, really, really incredibly diverse. And so, for example, one of the things that I think is coming down the pike, there's just but a few drugs approved in oncology for maintenance therapy. It's 3 or 4 drugs that are approved for maintenance therapy. The number of clinical trials that are looking at maintenance therapy right now are enormous. It's somewhere like in the 130, 140 clinical trials that are looking at maintenance therapy. Maintenance therapy is going to become something very important and very common in oncology, where you realize that I can't cure this patient, but I have a monotherapy now that is keeping the disease growing at a slow rate. In that situation, it's going to be really important to know what is happening to this rate as it goes along. And you can't get that by measuring a couple of lesions one time and a couple of different lesions the next time. And if physicians are going to do this properly and rationally and based on the data that is in the literature, they're going to need to have consistency. And something like this is going to provide that consistency for them. So I think that we don't have it now, but it's going to become essential. And I could see where it could even be a requirement. You know, a pharmaceutical, not a pharmaceutical company, an insurance company will be happy to pay for something to be continued, provided there is clear, objective evidence that it's doing what it was supposed to do, especially if it's a very expensive drug. And in order to know that, you have to have consistency in your measurements and in the reporting. So I think that it could be something that's forced upon us. Even if we don't do it in time, so we might as well do it before it gets to us.
Dr. Folio, do you want to add to that?
No, I can just agree from our perspective as radiologists. We know that we need to do better. It's just that the tools are just now becoming available, and now we just need to collaborate and communicate and discuss what standards we're going to agree on, such as the exportation of the measurements. We're working with a few universities to export our measurement data along with the images, kind of a teleradiology type thing, but more advanced than just the DICOM standards that have been established, but looking into standards of wrapping the data in things like annotation image markup, which American College of Radiology is also looking into and improving to be able to be more consistent in the comparison and data mining to make that more effective. We're trying to do it locally, but also working with other institutions to make it exportable and consistent as well.
Now, are you talking about in a research setting, or are you talking about in a community setting?
In the research setting,
branching this out and sharing information and, you know, assessing, you know, patient therapy progress or failure, I guess. Is that a future goal of this project?
I think now that you've added that clarification, yeah, this would be everything from a community setting where a cancer may be discovered at a local hospital, non-research, then referred to another center that might be an oncology setting or research setting, but to be compatible with measurements and images such as the DICOM standards that have occurred in the past, but more advanced to include measurements and tabulated data that now is more three-dimensional, especially since we're going to be routinely including volumes at several of the institutions, because many of the cancer centers are realizing that we need to go in that direction. So the standards have to be a little bit more complex than they used to be. So I would say everything from community to local oncology and research to more detailed research centers. So across the spectrum, essentially.
Yeah, and I was talking about
so do you see this as, yeah, Dr. Fojo, go right ahead.
No, I was talking about the cross the spectrum as well. I mean, I think this is going to become essential in private practice out in the community to really have precise data that tells you exactly what's happening and that it's becoming in a repetitive manner that is easily interpretable and is valuable and not haphazard. So, and I also think, actually, to be honest, I can't believe that radiologists won't benefit from this enormously. So everybody would rather be on the same page and know that what I'm measuring was measured by someone before and it's valuable and I'm doing this. And so I think that once it gets started, even if a different radiologist is measuring it this time and last time, and they know what were the index lesions, what was measured, right there, they go right back to that and they look at it. You know, then obviously a quick glance of the scan, they might find something that, oops, wait a minute, now there's a new lesion in this place or whatever. But otherwise, we need standardization as to what's happening to the lesions, not just in research. In the community, that's incredibly important. There's a lot of patients that will be getting, as I say, maintenance therapy just because you're at the end of the line or you don't think that the other alternatives are valid in this patient for whatever reason, toxicities you're concerned about or whatever, and you're going to continue the therapy that you're administering. So then you want tangible results that you can rely on to say, okay, this is progressing, but at a very measured pace, and I think it's valuable for my patient. So I could see someone getting scans over and over again for months and months and months, and there has to be consistency in this. So I'm talking about the community in this case.
Right. So therefore, you're saying that this software, this lesion tracking software, is very practical from the research facility perspective, which you're already utilizing it from, as well as just being used in the mainstream. I mean, it's something that is a good tool across the spectrum.
Yeah, I actually think in the mainstream is where it'll be even more valuable, because in the research setting, I know what I am following, and if they give it to me, fine. And if not, I'm going to go down and say, no, look, I know you measured these lesions, but these are the ones that I need values for. So I'm going to drive what gets measured, okay? So, but
right.
You can't expect, 50 medical oncologists scattered throughout the community that are getting the information from one radiology center to all be calling in and saying, hey, no, I want this, I want that, and so forth. So they're going to have that be done proactively for them, if you will, by the radiologist, who I think if you say to an oncologist, hey, part of my service is I'm going to provide you reliable, consistent measurements of the same lesions, information that you can use and, basically make better decisions with your patients. I think that'll be enormously attractive to the oncologist. There were two practices of radiologists, and one was offering that and the other one wasn't. I can tell you right away where I would go. I'd say, okay, why don't you go get your x-ray at this one place rather than the other? Why? Well, because they actually give me information that is very valuable. So I think it'll happen.
And if we go ahead, no, keep going.
No, that's it.
Okay. So what I was going to say too is what about workflow? I mean, what about the oncology cancer center workflow? I mean, what enhancements do you see happening there?
I mean, I think the same thing. I think that, again, anything that streamlines the process and that makes it more reproducible. And as I say, you're going to have different oncologists measuring, different radiologists measuring things every time. It's better if everybody knows what to measure. That'll make it incredibly more efficient. I think it'll be easier for radiologists to read. They'll know what has been valuable to the clinician before, what information they're relying on, and I'm going to give that there. And rather than sit there and wonder what it is that they want, I wonder if they're interested in this or that or whatever. They want to know, is there anything new that is dangerous? And then otherwise they want to know what's happening with those same lesions that I've been measuring over and over again. What pace of disease are we talking about here? So, it's remarkable.
Dr. Folio, do you want to add to that?
Yes, the workflows are still being established, but what I've seen improve over the last year, just heading in this direction, preparing for the future, is integrating what we call our Central Information Processing Services, or CIPS. And this is similar to what other centers have under various names, where radiologist extenders, including CT technologists that are kind of super technologists, will work with the oncologist and oncology nurse practitioners kind of as oncologist extenders, where a lot of this work, the workflow can be done behind the scenes before the radiologist. It's usually after a radiologist reads the traditional report, but because we have yet to streamline these workflows the way that we intend to over the next year or so, is to utilize the extenders to minimize interruption of the radiologist workflow and the oncologist workflow, since consultations, as Dr. Fojo mentioned, if we didn't measure the right index lesions because we didn't have the history, or because the radiologist was just doing the traditional, what we've been trained for, qualitative report, that consultation has a time cost, and we're trying to evaluate those time costs. Some are a little bit less tangible to wrap our hands around and measure, but we've seen a definite increase in our information processing to the point where we've been able to justify hiring a radiologist dedicated to tumor measurements and 3D processing and other areas where the traditional radiologist workflow outside of the tumor measurement radiology workflow continues on without interruption. But this additional radiologist has helped us tremendously. And as we progress towards this direction and we start to close, we continue to close our communication gaps with oncologists, such as this seminar, with both oncology and radiologist perspectives, and we start to get more detailed histories where we know that this is the type of cancer, the baseline study we're comparing with was this particular date, or say the best response or the nadir, to know what exam to compare to. Closing these communication gaps and integrating oncology nurse practitioners and super X-ray technologists in measuring the lesions, it becomes simpler and will save time in the long run. We haven't measured that particular part specifically, but we have measured the time savings in the lesion tracking, as you can see from some of the prior articles. But we are working on the oncologist surveys and the workflow time efficiency, if you will.
Okay. Just one more question. I want to be mindful of everyone's time because we're getting close to the end of the webinar here too. But you talked a little bit about the study that you had done. But I mean, obviously everyone's concerned about efficiency and time and things like that. What kind of time savings were involved in? I mean, obviously we're trying to do it always right, but we always are trying to be a little bit quicker and more efficient with our time as well. But from the radiologist perspective, what kind of time savings have you experienced?
That part we have yet to measure. The article that I was referring to, the AJR article in September 2013, the consistency and efficiency was more from the radiologist extenders, where this was not radiologists in their actual workflow. That was just use of the tool versus not use of the tool. So that was more kind of in a laboratory setting. The radiologist workflow, I'm currently timing how long it takes me, for example, to do a baseline and a follow-up study, since those are different for obvious reasons. And I've yet to do the timing for the new workflow. And it, again, it's hard to get our hands around. But the automation and the measurement, once we start implementing it, I think there'll be a tremendous time savings and overall improved efficiency when you take into account the additional consultations that are necessary. As Dr. Fojo was mentioning, that we didn't measure exactly what he wanted, and we've got 50 or 100 other oncologists we're working with where they often will come down to the radiology department, which is encouraged. But at the same time, if we can save the measurement part of that, then I think there'll be obvious time savings in the long run. This is clearly the direction to go. And standardization, so automation is only going to help that.
Excellent, excellent. Just one last question. I know, I mean, obviously here we're targeting cancer, but do you see other applications in the future as far as other diseases that could be assisted with, the diagnosis and the patient management that this software offers?
I think so, and I'll let Dr. Fojo express his perspective. But since oncology is our biggest business here at NIH Clinical Center, but a good percentage is also lung diseases and lymphoma or other lymphoproliferative disorders, ALPS, anything that requires measurement or splenic volumes or other organ volumes, automation of the segmentation is clearly going to be, I think it's going to be just a necessity. We're going to come to expect it, especially today's generation that's growing up with computers and gaming and this type of interactivity. And it is surprising that we haven't come along further. But yeah, there's many times when volumes are needed. We're doing research also in specific radiation dose for a patient, and not just for that patient and their size. But we're doing a study with organ dose estimation and segmenting of every single organ. Our goal in 5 to 10 years is to segment every organ of the body, and we've succeeded in everything, including small bowel, lymph nodes, and even approximating bone marrow for patient and organ-specific radiation doses, for example. So that's my perspective on, or my thoughts on the future of that.
Dr. Fojo?
Yeah, I wasn't aware there was something other than oncology. I thought that was all there was in medicine. But no, just joking aside, I could see that there would be other things. For example, I could see that, measuring liver volume, for example, which nowadays when we want to get it done seems to be, a pretty dose-intensive sort of, or intensive sort of process. something like this could help hepatologists who are following patients with, chronic liver disease and what's happening to cirrhosis and so forth and on. So I can think there'd be an enormous number of things. And then if I could just have quickly, by the way, I didn't want it to appear that the radiologists were at fault. In fact, the radiologists go around measuring different lesions because the oncologists didn't tell them what they were interested in. Usually the request is X-ray, patient on chemotherapy, and that's about all the information that they get. And the other thing is, I think the radiologists will save time, but I also think the oncologists will save time because if they've got that information, they don't have to pursue it further, even if you're just following something and then, but I really wanted to know about this or that and it hasn't been commented on and that's what we're measuring. That takes the oncologist time. So I think it's going to be efficient all the way around and everybody's going to be much happier once this becomes a much more efficient process. So.
Excellent, excellent. Well, that's great. I really appreciate all of your terrific answers. We're going to stop here based on time. Dr. Folio and Dr. Fojo, thank you so much for being a part of this afternoon. And thank you to everyone for sending questions and listening in. I know I definitely learned a lot. And if you would like to listen to this webinar again or forward it along to a colleague, we will be sending you a link to it tomorrow. Otherwise, you can also view it on clinical-innovation.com. And thank you so much and have a great day.